with you. Thank you.
Thank you, Dr. Andreas. That was a wonderful presentation. And it just highlighted the vast spectrum of cytology that you have shown for us with beautiful images. And congratulations to you for showing a wonderful spectrum. I would like to now call upon our next keynote speaker, Dr. Kelly Elliott from the Northern Health and Social Care Trust, UK. Dr. Kelly, please take the stage. Thank you.
Thank you very much. Apologies for the delay this morning. I had some technical difficulties, but hopefully we're good to go now. Is that okay? Can that be seen?
Yes.
Excellent. So first of all, thank you very much for the invitation to speak today. It's my very great pleasure to join you at the Emirates conference. It's only my disappointment that it's not a physical presence and we can't be together and meet up properly. And so in that instance, I thought I'd share my first few slides just letting you know a little bit more about me. Obviously, if this was a physical presence, we'd be able to chat and get together during the breaks and find out more about each other as colleagues across the globe. So that being said, this is where I am. So this is Northern Ireland, a very little small part of the UK. First day of winter here, it's about 5 degrees outside and some snow forecast for later in the week. So maybe a little bit different than where most of you are joining us from this morning. I'm a graduate from the Queen's University in Belfast. It's the capital here in Northern Ireland. Small country of only about 1.7 million people. Sorry, is my being interrupted? Can everybody else still see my slides? Because I can see somebody else's slides now.
Dr. Kelly, I think we're seeing another screen online. Just give us a minute, we'll get back. Yes, I think we're back.
We're back, okay, that's grand. Yeah, so I'm a graduate from the Royal College here in the UK, and I'm also an British Army medic. This is the Royal Military Academy here at Sandhurst in England, where I graduated from back in 2014. So I have a military career as well as a medical career. And this is the hospital where I work. This is District General Hospital called Antrim. It's the town in which it's located, and you can see the tarmac here in the car park. It's not that it's particularly shiny, it's just that it's wet. So Ireland is very wet and very green, which hopefully you can pick up from the grass there in the front of the hospital. So pathology obviously is why we're all here today. It's a very exciting time, I think, to be in pathology. So we've had obviously light microscopy for a long time. Currently we are shifting over to a digital platform ourselves, and I was very excited to see Andreas's beautiful images and photographs there, and hopefully next year I will be working under the same sort of circumstances. But I mean, we've come so far of late. We now have so much molecular technology between FISH and KISH. We're also all moving probably to next generation sequencing and all the exciting revelations that that's likely to bring with us. And we've also just embarked on flow cytometry this year as well in my laboratory, which is also very exciting. I do a little bit of hematopathology as well as breast and a few other general disciplines. So I think it's a very exciting time for all of us, and lots of new innovations, and hopefully conferences like this, whether they be physical or virtual, or maybe in the future a combination of both, will facilitate all that sharing, which will be lovely. So yeah, so a little bit more about me, just if we were at coffee break and we were chatting. This is the big Army Field Hospital training facility in Leeds in the north of England, and this is my team working on a trauma scenario. We do lots of role play scenarios with live casualties to make us as good as we can be whenever we get to a real theatre. This unfortunately is not the Burj Al Arab. This is Plymouth at the bottom of England, right on the coast. And when Ebola unfortunately raised its head back in 2015, this is where we had our big pathology conference with the army to decide how we would test and how we would look after our people when they went to West Africa to help care for those with Ebola. Outside pathology then, lots of other interests. I like skiing, walking. I've been fortunate enough to trek across the Grand Canyon from rim to rim. I also like motorsport. This was my first car as a young person. It's a British Mini Cooper of sort of the old classical type. Very small, very rattly, very cold, but lots and lots of fun. And then obviously, yeah, travel. So Emirates, one of my favourite places, and I've been very fortunate to attend the Grand Prix and stay in Yas Island during that week in November. So hopefully whenever COVID is resolved and we're all allowed to go out and about again, it would be my great pleasure to attend the conference in person. So this is me. If there's anything about today you'd like to ask or follow up on in regard to the presentation, I'd be more than grateful for anybody to get back in touch. So moving on then to the actual topic at hand, enough about me. So today I'd like to present a case, just an interesting case report that hopefully has some connotations and lessons for us all and ties in a lot, I think, with what Andreas was saying too. So this is a case of a 75-year-old lady, and she presented to hospital with symptoms of a lower respiratory tract infection, not too uncommon, probably makes up a great majority of our presentations. So she had some imaging investigations, quite typically so. She had a CT scan, which showed that she had some mediastinal lymphadenopathy, which had a necrotic appearance. And we tried to perform an EBUS FNA on that sample, but unfortunately the patient was quite unwell and unstable during that procedure, and we weren't actually able to get any tissue from that. Also on her CT of note then, in the abdominal cavity, she had some apparent thickening in her descending colon and also somewhat soft tissue changes in her omentum, which looked very concerning for omental metastasis. So all in all, a rather concerning picture and worrisome for a malignancy. The site perhaps not too obvious, although you'd be worried about the colon as a primary site. In her chest then, there was also some suggestion of some pulmonary metastasis. So the working diagnosis was that she probably had a colonic cancer, which had spread to her omentum and also into her lungs. So in order to try and identify that primary site and get a tissue diagnosis, she was referred for a colonoscopy. So at the colonoscopy, there wasn't actually any tumour seen, just this little small 2mm polyp in the hepatic flexure, which doesn't seem like a likely culprit for causing such widespread metastasis, but nevertheless, the polyp was retrieved and came down to the lab for histopathology. This is the H&E section. Andreas is going to put me to shame now with his beautiful digital images. This is unfortunately a standard light microscopy H&E processed glass slide, but hopefully you can appreciate the colonic mucosa around the top here. Maybe a little bit of something in here which is also occupying this subepithelial layer down in here in the submucosa. Looks concerning for tumour. Colonic mucosa over the top looks okay, no dysplastic change there. Close up then, quite a regular arrangement, nothing very pleomorphic about this. Some sort of suggestions of rosettes perhaps in and around, but relatively monotonous and rather bland tumour. Some trabecular arrangements as well, little nests, and not very much in the way of mitotic activity. So not what you would think of carcinoma. So differential, I originally came up with probably a neuroendocrine tumour. Was this all just a coincidental neuroendocrine tumour? Is it carcinoma with a bit of neuroendocrine differentiation, or a mixed neuroendocrine tumour, as we call them now, a mimicking? Or could this be metastatic from outside and actually the colon was a bit of a red herring and indeed not the primary site at all? So back on this lady's admission. This was her chest x-ray, and the more astute of you may notice a little anomaly, which is going to give us all a clue as to where this case is going to end up going. May want to look at the breast shadows. I'm not going to give the game away. I'm going to try and keep you guessing if I can, but I'll give you a bit of a clue to look for the breast shadows if they project hopefully well enough on your computers at home. So what did we do? Immunohistochemistry, of course, the go-to for everybody in pathology these days. Thankfully, we don't have to rely too much on morphology. Of course, it's always important, and we always should pay attention to the morphology, but I think at this point we all would have reached for some immunohistochemistry. So these are the markers that I did: CK7 and 20, GATA3 and ER, thinking about breast, CK50 or CD56 and synaptophysin, thinking about neuroendocrine tumour, and Key67 in case if it was neuroendocrine, then I would have the ability to grade that tumour. So what did I find? CK7 was positive, but 20 and CDX2 were both negative. So while it doesn't take us totally away from a colorectal primary, it would make an upper GI primary perhaps a little bit more likely. Looking at the breast markers, both of those were strongly positive, both ER and GATA3. Thinking about the neuroendocrine markers then, positive staining for synaptophysin, but negative CD56. 56, of course, being a more sensitive neuroendocrine marker, so you would imagine it would be very difficult to have a neuroendocrine tumour which wasn't positive with CD56. It tends to be more sensitive and less specific. And the proliferation index with Key67 of around 10%. So back to our light microscopy image. This is the colon I showed you before with tumour in below the submucosa, and this is the synaptophysin staining. So no doubt about the synaptophysin positivity, and interestingly then the GATA3 almost identical, nice strong positivity all the way through. So this is what I had after the immunohistochemistry. So a little bit of a puzzle, shall we say. 7, GATA3 and ER would all go with breast, but the synaptophysin throws in that sort of neuroendocrine suggestion, but the negative 56 would take you away from that. So this, again, back to my list of differentials and what we thought this lady might have. Of course, it's important because a little coincidental neuroendocrine tumour could be excised, and that would be the end of the story, hopefully, and she would be cured. However, if this represented a breast metastasis, then this is a very different pathway for this patient and really suggests that she then has disseminated disease with those omental and pulmonary nodules that we've seen on the imaging. So if we go through each of the markers in turn and look at the differentials with the fors and against. So GI, CK7 positive, synaptophysin and ER. ER you can definitely see in gastric cancers, especially those of the diffuse type. But against that then CK20 and CDX2 again more from a colorectal primary. And CD56, as we've already said, is a more sensitive neuroendocrine marker, and therefore with it being negative, you would like to discount a neuroendocrine tumour. Which is essentially what I'm saying here again. The CD56 being negative really makes this very unlikely to be neuroendocrine. Thinking then about metastatic breast, again, CK7, GATA3 and ER, all strong evidence that this is most likely a breast carcinoma, but randomly the positive synaptophysin, what does that mean in this context? So thinking about our immunohistochemistry, very little change in the results from this panel would have a big bearing on what we think is going on. For instance, if our CD56 had come up falsely positive, I think you would be much more inclined to have called this a neuroendocrine tumour. Interestingly, if the GATA3 perhaps had been very weakly positive or falsely negative, then again, this panel, you would absolutely have thought mostly about GI, primary and neuroendocrine differentiation, which is obviously very different than having a metastatic breast carcinoma. So this takes me then to a paper that I wrote a few years ago now with the help of Professor Santeteles at the university here in Belfast regarding validation and verification for immunohistochemistry. Every year there are new markers which come onto the market, papers written about them and case series about where they appear positive and how they can help us. And then, as most of us have probably realized by now, inside a few years there are anomalies and reports then of other incidences where the marker perhaps also stains and it becomes a little bit muddy in the water and things are not quite as clear cut as hopefully we would have liked. So what we tried to do in this paper is come up with a way of validating and verifying immunohistochemistry so that it would be as robust as our molecular diagnostic techniques that we have. So whenever we do PCR for EGFR, or we look at MSI or any of those other markers, especially now those that are associated with drug targets such as ALK and ROS1 and non-small cell lung cancer, it's absolutely imperative that we get those right. We don't want to deny anybody an opportunity of a drug which may help their survival. So with immunohistochemistry coming on board, acting as a surrogate molecular marker for these tests, I think it's really, really important that they are as reliable as they absolutely can be. So in this paper, we looked at Ki67 and P53. Both of these markers are widely used in a very broad spectrum of dysplastic and malignant processes. Personally, I use it quite regularly when I'm thinking about dysplasia, perhaps in a segment of Barrett's. I use it if I'm suspicious of STIC, so a pre-malignant process in the fallopian tubes arising before an ovarian malignancy. Typically look at that for ladies who have BRCA mutations, who are having prophylactic BSO. Neuroendocrine tumours, of course, we need Ki67 to grade those, and that then decides what treatment pathway a patient will go down. And for the epithelial ovarian tumours, high grade, low grade serous, clear cell carcinoma, P53 is a big player in how we decide which one of those we're going to classify. So I think these two markers are a good example of why our immunohistochemistry has to be really robust and very accurate. So we looked at a variety of settings, including EQA schemes across the world, so quality assurance schemes, where laboratories were sent centrally stained slides, all from the same case. And the variation in the scoring for P53 and Ki67 was quite excessive. The range in numbers that we've seen people calling their Ki67 rate, the variety really was quite broad. And so in order to try and perform more robust validation, we came up with a proposal of a stepwise approach as to how a laboratory might go about more robust validation, especially when you're bringing on board new markers or for a new laboratory setting out. And as I said before, obviously all of our markers are increasingly important for diagnosis. We rely more and more on them. We're being sent tissue from weird and wonderful places. And with COVID, I think most of us would agree that we are seeing more disseminated metastatic disease, and our caseload increasingly is becoming a search for a primary site. And so we often have poorly differentiated tumour where there's not an awful lot of morphological clues where it has come from, and we're relying increasingly on our immunohistochemistry to steer our clinicians to where the primary might be. Often these patients are not curative, so they're not having definitive surgical resections to shore up our diagnosis, and therefore we're relying on these diagnostic cores to guide our treatment plan for these people. Also, we have these surrogate molecular markers, which are immunohistochemically based, so the likes of ALK1, ROS1, which we're using for our non-small cell lung cancers, and also the older ones, which we'll all know, estrogen receptor and Herceptin markers for our breast carcinomas and also in our gastric carcinomas. Again, we don't want to deny anybody an opportunity for a drug target which might help them just because our immunohistochemistry isn't up to the job and isn't performing the way it should. So, as I say, that paper, if you're interested or you take to do with the molecular diagnostics and the immunohistochemistry validation for your laboratory, is quite a robust stepwise approach as to how we can shore up our immunohistochemistry. And really, it's a continued process. Every time new markers come on board, when there's new batches, when there's changes to equipment, it's worth running through this checklist and just being confident in your immunohistochemistry. So back to our case report. So there are 3 differentials of a GI primary with some neuroendocrine differentiation, a standalone neuroendocrine tumour, or metastatic breast carcinoma. So all of these obviously would have a very different outcome for this lady, depending on which we decide to call it. So those of the more astute earlier from the chest x-ray may have noticed this lady only had 1 breast shadow. So what was hidden was that she had had a previous mastectomy for breast carcinoma. And this was performed outside of the country. So although we have a very helpful electronic care record here in Northern Ireland, which holds all of our patients' bloods, imaging and clinic letters, this lady had previously lived outside of Northern Ireland, and so this wasn't actually seen by us, and clinicians didn't think to mention that she had a history of a breast carcinoma, of course, as they often fail to tell you something important like that. But the pickup then of the chest x-ray, and we asked the question, is there a history of breast surgery here? And then it came out that this lady had had a grade 3 infiltrating duct carcinoma 5 years previously, and that was stage PT2N1, so she had node positive disease. And we requested those slides then from the hospital where it was performed, and there was some focal areas where there was a papillary growth pattern in that tumour. So we set the 2 tumours then side by side and realised that morphologically they were quite similar. And we also carried out SYNAPTOPHYSIN immunohistochemistry on her tumour block from the breast cancer and found that it actually was also positive with SYNAPTOPHYSIN. So this then unified the whole story for us. So this was her breast carcinoma. Hopefully you can pick out here the sort of palisade almost, and the vague rosette formation that we've seen in the colonic tumour also. Maybe a little bit more pleomorphic than what we had in the colon, but obviously the breast carcinoma was a bit larger and a bit longer to grow and become a little bit more pleomorphic, but not dissimilar at all than what we've seen. And this was her SYNAPTOPHYSIN again, so I apologise for this picture. This is a horrendous photograph of the light microscopy image, but you can take my word for the tumour morphology, but the SYNAPTOPHYSIN here obviously strongly positive. So what do we know about SYNAPTOPHYSIN then in breast carcinomas? So a subset of breast carcinomas with papillary morphology such as this one do exhibit some SYNAPTOPHYSIN positivity and have some neuroendocrine differentiation. By comparison then, if this lady had had a colon neuroendocrine tumour, they are in fact quite rare and only make up about 10% of the gastrointestinal neuroendocrine tumours that we see. The vast majority of them are small bowel or gastric, but I think most of us would say in our general work we see more small bowel neuroendocrine tumours possibly than anywhere else. If this had been a colonic neuroendocrine tumour, they typically come about quite late, and patients already have metastatic disease. But like ours, they do frequently turn up just as little incidental polyps. So during bowel screening procedures, colonoscopies for other reasons, you often pick them up as polyps sent in by our endoscopy teams. So in conclusion then, we decided that this colonic lesion was indeed a metastasis from the previously diagnosed breast cancer, and by default then both the omental metastasis and pulmonary nodules that were seen were also felt to be malignant by our radiology team. And so this lady was unfortunately put onto a sort of palliative care pathway. She had disseminated malignancy with no option really for curative intent. She had already had chemotherapy and radiotherapy at the time of her breast diagnosis, and so her options were a little limited now. Metastatic breast carcinoma, not uncommon. Most frequently probably picked up in endometrial polyps, especially patients who have had tamoxifen, sort of estrogen-driven growth there. But on my literature review on writing up this case, colonic lesions do appear to be much less frequent, and typically lobular carcinomas, of course, are famous for disseminated malignancy, and they seem to appear more commonly in weird and wonderful places. So what can we take away then from today? So morphology, obviously, still very important, and without morphology and having some clues as to where we might be going with our primary site, it's very hard to come up with a good immunohistochemical panel. So I think the morphology should always guide us first. So in this instance, the tumour site, the bland morphology, and that synaptophysin positivity, very easily you could have been led astray and called this a neuroendocrine tumour. So the clinical history really is of paramount importance, and finding out about history, I mean, we're all taught that as medical students right from the off. You know, the answer is almost always in the patient history if you can just get them to tell you the right information. However, in tumours with a little bit of papillary architecture, do think about metastatic breast carcinoma. This lady had a previous diagnosis, but of course this could well have been a presenting pathology in this, equally as likely. So it's worth remembering that. And also immunohistochemistry needs to be robust and reliable so that we can be as accurate with our diagnoses as possible. So takeaway points then. Just a little interesting presentation of metastatic breast carcinoma occurring as a colonic polyp. But I think the bigger message to take from this, always keep your mind open when you see something that doesn't quite ring true. So the markers that this little polyp we're staining up with didn't quite sit with a neuroendocrine tumour, and it was worth digging deeper. But also I think the most important thing to learn is that we have to have faith in our immunohistochemistry, and very little change in a panel can make a big difference. Some examples I personally have encountered of late where the diagnosis is really hinged on just one marker, perhaps things like sarcomatoid mesothelioma, often may only stain with one of the mesothelial markers, and so it can be very easy to think it's negative for mesothelioma. Equally, sarcomatoid carcinoma, again, you may only have one positive cytokeratin and discount the idea of a carcinoma, or indeed spindle cell melanoma or desmoplastic melanoma may only stain positively with a single marker, and again it can be very bland, of course, morphologically as well, and it can be easy to discount a diagnosis of melanoma. And all of these obviously are time critical diagnoses to make, and as I said earlier, we are all expected to perform more and more diagnostic tests on smaller and smaller volumes of tissue, while also having in our mind that we need to perhaps retain tissue for molecular analysis or biomarkers which have drug targets. So we're trying to do as much as we can with as little tissue and keep what we have, especially in times of COVID, where we are perhaps seeing more patients who have disseminated malignancy, and this is our only chance perhaps to make a diagnosis for them. So robust validation of immunohistochemistry and validation, I think, are imperative for us, especially today. So you probably won't be able to read that, but if there's any of the references or a copy of the presentation or the paper from the best practice paper